The aim of this video is to provide a brief introduction to workplace-based assessment in the context of competency-based medical education. Up until the mid-2000s, specialists were trained in the apprenticeship C1, Do One, Teach One model, and completion of training depended on clinical exposure during a fixed training period, usually 4 to 5 years, as well as an exit examination that primarily assessed knowledge. However, there's been recent changes in the healthcare environment. There are more trainees, so the 1-to-1 apprenticeship ratio is no longer feasible. There's increased specialization and subspecialization. There's increased administrative burdens on both specialists and trainees, increasing pressures on efficiency, ethical issues with training on patients, and finally, escalating rates of litigation for medical errors. All of this means that university programs and examining bodies need new strategies to ensure and prove the competence of graduating trainees. The new method of training and assessment is competency-based medical education, which is defined as an outcomes-based approach to the design, implementation, assessment, and evaluation of medical education programs using an organizing framework of competencies. The Health Professions Council in South Africa has put together such a framework, which is based on the Canadian CanMeds framework, which contains a central organizing role, being the healthcare practitioner with skills and knowledge included in the day-to-day activities of that practitioner, and then the intrinsic roles, which would be the communicator, talking to patients and families, collaborator, working with other members of the multidisciplinary team, being a leader and a manager, being an advocate for patients, being a scholar and a professional. One of the core components of competency-based medical education is programmatic assessment. And this includes many raters and multiple assessment methods over time. That assessment is not just of learning, but also used for learning. That high-stakes decisions are made within a training program by a group, for example, a competence committee, and not just by an individual, typically the department chair. And finally, a greater emphasis on a workplace-based assessment. To put it into perspective, competency-based medical education is the broad framework. Programmatic assessment is a component of that, and workplace-based assessment and high-stakes decision-making by a competence committee is part of programmatic assessment. Now, what is workplace-based assessment? It is the assessment of working practices based on what trainees actually do in the workplace and predominantly carried out in the workplace itself. You may ask yourself, why do we need this? Well, traditional assessments were based on written or oral examinations of primarily theoretical knowledge. And these fail to assess the wider domain of competencies that are required by trainees or specialists in daily practice. This is especially procedural, but also other intrinsic competencies like communication, collaboration, leadership, etc. Workplace-based assessment was introduced in the early 2000s, and it provides direct assessment of what trainees actually do in the clinical environment, which means it's got greater validity, especially face validity, and other methods to measure competence. And it's been widely adopted globally. Now, entrustable professional activities were introduced to make the connection between competencies, which are characteristics and abilities of learners, and the professional activities that are entrusted to them once they graduate. So in essence, they break down a specialty into units of practice that can be assessed and certified, and therefore provide the scaffolding for specific workplace-based assessment tools. Entrustable professional activities are based on the concept of trust, which is familiar to clinicians, and it's practiced implicitly on a daily basis. An entrustment scale is used to describe trainee independence at performing a particular activity, and the scale ranges from the trainee just observing to direct proactive supervision where the supervisor actively participates, to indirect reactive supervision where the supervisor is present in the room and readily available, to unsupervised practice where the supervisor is not in the room but can be available at short notice. They are often still in the building. And finally, a trainee that is so competent they can supervise others. Some important principles of workplace-based assessment is that individual assessments are low stakes and have a formative focus, and therefore assessment is used for learning. And thus observations may be a preferable term to assessments, which can be a term that invokes some anxiety with trainees. The subjective judgment of an expert clinician is highly valued, rather than psychometric scales saying 0 to 5 or 0 to 100%. And the reliability comes in with multiple observations from multiple sources over time. The individual workplace-based assessments or observations are then entered into an e-portfolio, which is reviewed by a group periodically to make high-stakes decision on whether a trainee progresses or not. So the portfolio may contain workplace-based assessments of these entrustable professional activities, end-of-block assessments, in some settings called in-training evaluation reports, and a logbook may also be used, especially for the procedural disciplines, as it captures exposures that are important goals for registrars to be exposed to, but fall outside of entrustable professional activities. And finally, high-stakes decision-making is made by a competence committee, and this is usually around 5 consultants, but it may range from 3, some have even ranged to 20. It really depends on the local context. They meet periodically, often 6 monthly. Each registrar's progress portfolio is reviewed in depth. The reviewer of that particular registrar makes a recommendation to the committee, and then this is voted on such that a group decision is made. This is then communicated in some way to the university, whether to a specialist training committee or the deputy dean. And finally, feedback is given to the trainees on their performance. So in summary, workplace-based assessment is a part of competency-based medical education, which is the modern method of training and assessment of postgraduate medical specialists. Workplace assessment allows the assessment of competence in the workplace, and it's got significant formative value by utilizing assessment for learning. The framework for assessment in the workplace is provided by entrustable professional activities, which make the connection between competencies and activities. Multiple low-stakes observations from multiple raters are then entered into an e-portfolio, which is finally reviewed by a competency committee to make high-stakes decisions regarding progression and finally eligibility to write the exit examination.